professionals rapidly decode chest pain to save lives.
It's very much a race against time.
Think of it as a detective story, really, where the ticking clock is entirely literal. And we are going to look at the exact cheat sheet doctors use to outsmart death.
And, outsmarting death actually begins with a concept that shocks a lot of people outside of medicine. It's considered the golden rule of chest pain triage.
Because I think the assumption most of us have is that the doctor's immediate goal is to figure out exactly what is wrong with you as fast as humanly possible.
Which, that is the logical assumption, right? But the golden rule actually dictates that in those first 1 to 2 minutes, the goal is explicitly not to make a final diagnosis.
Wait, really? Not to make a diagnosis?
Not at all. Making a final nuanced diagnosis takes time, and time is a luxury you just do not have when someone is crashing.
That makes sense. So what are they doing?
The singular overriding goal of those first few minutes is to identify or completely exclude immediately life-threatening causes. You aren't looking for the correct answer. You're actively hunting for the absolute worst-case scenarios.
I love that. It actually makes me think of a bouncer at a really exclusive high-security club.
Oh, that's a great analogy.
Right, because when you walk up to the door, that bouncer isn't checking your ID to verify your address or, what you do for a living. They're just aggressively patting you down to make sure you aren't carrying a weapon.
That is exactly it. The doctor is doing a rapid physiological pat-down for what the medical training frameworks call the deadly six.
The deadly six? That sounds ominous.
It is. These are the 6 major killers that can present as acute chest pain. And because human memory can really falter under extreme stress, doctors use a specific mnemonic to scan for them instantly.
And that mnemonic is "Apeat me."
Yep, apeat me.
Let's run through these 6 weapons the bouncer is checking for, starting with the A.
So A stands for aortic dissection. The aorta is the main massive artery that carries high-pressure blood straight out of your heart to the rest of your body.
Okay.
And in a dissection, the inner lining of that artery actually tears.
Wait, so blood starts pumping into the wall of the artery itself?
Precisely. The immense pressure of the heart pumping forces blood between the layers of the artery wall. It physically strips it apart from the inside.
Oh, wow. That sounds incredibly painful.
It is. That mechanical tearing creates the hallmark clue, which is an agonizing tearing pain that radiates straight through the chest into the patient's back.
Right between the shoulder blades, I imagine.
Exactly. Right between the blades. So that's the A.
Moving to the P in A. P
is for pulmonary embolism. This is a blood clot, usually originating deep in the veins of the leg, that breaks off, travels through the heart, and forcefully wedges itself into the arteries of the lungs.
So it's literally blocking the flow of blood trying to get oxygen.
Exactly. And the primary clue here is pleuritic pain, meaning it hurts sharply every single time the patient breathes in. And that's combined with a very sudden onset of shortness of breath.
Okay, so that's A and P. What about the first E?
Esophageal rupture.
The esophagus, like your throat.
Yeah, the muscular tube connecting your throat to your stomach. If a patient is suffering from violent, forceful vomiting, the immense pressure can actually blow a hole right through the wall of the esophagus.
Which means everything from the stomach is now entering the chest cavity. That sounds awful.
It's catastrophic. Stomach acid, undigested food, bacteria, it all leaks directly into the sterile space around the heart and lungs.
Causing massive infection, I'm sure.
Right, massive inflammation and infection. The history almost always involves severe retching that suddenly transitions into just unbearable chest pain.
Okay, then we have T.
Tension pneumothorax. This is a collapsed lung, but with a really deadly mechanical twist. A hole forms in the lung or the chest wall that acts like a one-way valve.
So air can get in, but not out.
Exactly. When the patient inhales, air gets trapped inside the chest cavity, but when they exhale, it just can't escape.
So the pressure just builds and builds with every single breath.
Until it becomes so immense that it literally pushes the heart and the major blood vessels to the opposite side of the chest. The heart gets physically kinked and just can no longer pump blood.
Wow. How do they spot that quickly?
The massive diagnostic clue here is sudden shortness of breath, accompanied by utterly absent breath sounds. When the doctor puts a stethoscope on that side of the chest, they hear absolute silence because the lung is completely crushed.
That is terrifying. Okay, what about the M?
Myocardial infarction, commonly known as a heart attack, or acute coronary syndrome.
The classic one everyone thinks of.
Right. A coronary artery gets blocked by a plaque or a clot, and a portion of the heart muscle begins to starve and die. The classic presentation is a feeling of crushing pressure or severe heaviness in the center of the chest.
And finally, the second E in arythmia. Now, looking at the source notes, the actual condition listed is cardiac tamponade, which obviously starts with a C.
Yeah, medical mnemonics sometimes bend the spelling rules to save lives.
Fair enough.
The framework suggests using that E to remember the sheer emergency of a tamponade. The heart is encased in this protective sac called the pericardium. It's a tough, unyielding membrane.
Yeah.
In a tamponade, fluid or blood rapidly fills that sac, and because the outer sac cannot stretch, the fluid squeezes inward, essentially crushing the heart.
So if the heart is being crushed by fluid, it can't expand to fill up with the next beat of blood.
Exactly. It's choking on its own restricted space. This presents with profound shock and something called a raised jugular venous pressure.
What does that look like?
Essentially, because the blood can't get into the crushed heart, it backs up into the body, causing the major veins in the neck to visibly bulge out.
Okay, so we have apetemy, aortic dissection, pulmonary embolism, esophageal rupture, tension pneumothorax, myocardial infarction, and the emergency of cardiac tamponade, the 6 deadliest weapons.
Those are the ones.
But how does a doctor look at a patient and actually know one of these is actively deploying before any machines are involved?
Well, they look for the direct threat clues. Which brings us to another critical framework.
Right, the warning signs.
Yeah, the warning signs that a patient is actively crashing are captured in the mnemonic SHOCKED, SHOCKED.
So these are the immediate visible signals that the patient's system is failing right in front of you. Let's break that down.
Sure. S is for syncope, which is the medical term for fainting or passing out. H is hypotension, dangerously low blood pressure indicating the pump is failing.
And the O.
O is ongoing pain for more than 20 minutes. That signals that the heart muscle is actively starving for oxygen and sustaining permanent damage.
Then the C is cold sweat or diaphoresis, right?
Yes, which is actually a fascinating physiological response.
How so?
The body isn't sweating because it's hot, it's sweating because it is in a state of massive internal panic.
The fight or flight response.
Exactly. The sympathetic nervous system floods the body with adrenaline in response to a catastrophic event like a heart attack, and that adrenaline surge triggers profuse cold sweating.
Now, the notes list K as kill-you dyspnea. I have to push back on this terminology a little bit.
Oh, why is that?
Well, dyspnea just means shortness of breath, right? We've all been out of breath after sprinting to catch a bus. What makes it kill-you dyspnea?
It is a really vital distinction, actually. Being winded is physiological, but kill-you dyspnea is a terrifying state of air hunger.
Air hunger.
Yeah, the patient isn't just panting. They are using every accessory muscle in their neck, their shoulders, their abdomen, just to drag oxygen into their lungs. They literally cannot speak in full sentences.
Wow, that paints a very different picture.
There is a sheer visible panic in their eyes because their brain is screaming that it is suffocating. It is the specific dyspnea of a pulmonary embolism or a tension pneumothorax, and it is unmistakable.
Okay, moving on to E in shocked.
E is for ECG abnormalities, which relies on technology we will get to in a moment. But D, the final red flag, is a differential blood pressure or pulse or a new neurological deficit.
Meaning the doctor checks the pulse in your right wrist and your left wrist, and they feel completely different.
Yes. Think back to the mechanics of the aortic dissection we discussed earlier. The main artery of the body is tearing apart from the inside.
Right.
If that tear acts like a roadblock and extends up into the arteries supplying the arms, it diverts blood flow unevenly. So the pulse in the right arm might be strong, but the left is weak or absent entirely.
And if that arterial roadblock extends up into the arteries supplying the brain,
you suddenly present with a stroke, a neurological deficit, right alongside the chest pain. The clues directly map to the mechanics of the threats.
I see. So coughing up blood points mechanically to a pulmonary embolism in the lungs.
Exactly. And sudden absent breath sounds point to the collapsed lung of a pneumothorax.
I'm looking at this from the perspective of someone trying to learn all of this, or even a patient experiencing it. I see Socrates, Opicurest, apetemy, shocked. It's a complete alphabet soup.
It really is, yeah.
Do doctors actually stand at the bedside and run through these letter by letter in their heads while a patient is coding?
Well, in the very beginning of their training, yes, they actually do. Yeah, but over time, it becomes deeply ingrained muscle memory. The mnemonics act as a mental scaffold, because under extreme stress, your cognitive bandwidth narrows. Having these rigid frameworks ensures that panic doesn't cause a doctor to miss a vital clue.
That makes total sense. So let's say the bouncer does the visual pat-down. The patient isn't exhibiting the shock savant or red flags. They aren't actively crashing.
Okay, a more stable patient.
Right. The doctor has ruled out immediate collapse. At this point, the doctor has to transition from a bouncer to an interrogator, trying to accurately measure something entirely subjective, which is the patient's pain.
You have to force structure onto a subjective feeling, and this is where those history-taking frameworks come in, specifically Socrates and Oki-QRS.
Socrates stands for site, onset, character, radiation, associated symptoms, timing, exacerbating or relieving factors, and severity.
Quite the mouthful.
It sounds like an ancient philosopher's interrogating my chest. And OPKRT does something very similar, right? Onset, provocation, quality, radiation, severity, time.
The goal of both is just to force the patient to move beyond simply stating, "My chest hurts." The specific words patients choose when prompted are massive diagnostic clues.
Like what?
Take the character or quality of the pain. If a patient describes the sensation not as a sharp pain, but as a deep pressure, a tightness, or like an elephant sitting on their chest, the doctor is immediately suspecting acute coronary syndrome.
What if the patient says it feels like a burning sensation?
Burning is notoriously tricky. I mean, it could be severe gastroesophageal reflux disease like GERE or heartburn, but it can just as easily be a heart attack. You can never rule out the heart just because the pain burns.
Okay, so if the pain is described as sharp, does that point away from a heart attack?
Often, yes. Sharp pain points more toward pericarditis, which is that inflammation of the protective sac around the heart.
Oh, okay.
And here is where the exacerbating and relieving factors of the Socrates framework become so crucial. If a patient says, "The pain is sharp when I lie flat, but it actually feels much better if I lean forward in my chair," that is a textbook mechanical sign of pericarditis.
Wait, why does leaning forward help?
Because leaning forward physically pulls the inflamed heart and its sac away from the inner wall of the chest, which reduces the friction that causes the sharp pain.
That is brilliant. But interrogating the pain itself is really only half the battle, right? Because the identity and history of the patient sitting on the bed completely changes the statistical meaning of that pain.
Oh, absolutely. We enter the phase of risk assessment. A 20-year-old athlete presenting with sharp chest pain is a fundamentally different puzzle than a 70-year-old heavy smoker presenting with heavy chest pain.
Right. To quickly tally up that historical risk, the framework provides the heart mnemonic, HEART.
Exactly.
H is for a history of hypertension or hyperlipidemia, so high blood pressure or high cholesterol. E is for elderly. A is atherosclerosis, meaning known artery disease. R is renal or rheumatic disease. And T is tobacco use.
The clinical notes also emphasize adding diabetes, obesity, and family history into that profile, specifically a family history of premature sudden cardiac death.
Makes sense.
But there is a very specific clinical pearl from the USMLE cheat sheet aimed at younger patients that catches a lot of people off guard.
Oh, I know the one. Always ask about cocaine use in younger patients with chest pain.
Yes. Cocaine is a potent vasoconstrictor. It causes severe, sudden spasms in the coronary arteries.
And those spasms can trigger a heart attack.
They can completely cut off blood flow and induce a massive heart attack in a young person who otherwise has zero conventional heart risk factors. The overarching rule these exams drill into young doctors is to treat every acute chest pain as a heart attack until definitively proven otherwise.
And this brings us to a part of the source material that genuinely stunned me.
The drug interaction.
Yes. It's listed as a critical alert. An absolute never-miss interaction in emergency medicine that involves a completely common lifestyle medication becoming a lethal trap.
It is one of the most dangerous pharmacological traps in the ER.
So a standard initial treatment to relieve chest pain and open up blood vessels is to give the patient a drug called a nitrate, like nitroglycerin.
Very common, yes.
But the source material has this bold, screaming warning. Doctors must never administer nitrates before asking the patient if they have recently taken PDE5 inhibitors.
Right. PDE5 inhibitors are the medical classification for drugs like sildenafil, tadalafil, or vardenafil.
Better known by their brand names, Viagra or Cialis.
Exactly.
So you are telling me that if a patient is too embarrassed to disclose that they took Viagra, the very medicine the doctor gives them to save their heart could actually kill them?
It is entirely possible, and the reason lies in the pharmacology. Both nitrates and PDE5 inhibitors work by massively dilating blood vessels, but they act on slightly different parts of the vascular system.
Okay, break that down for me.
Well, nitrates primarily dilate the veins, while PDE5 inhibitors dilate the arteries and capillaries.
So if you combine them.
The synergistic effect is catastrophic. The entire vascular system opens up at once. All resistance just drops to zero.
Wow.
And the patient experiences profound refractory hypotension,
Refractory meaning it cannot be reversed.
meaning their blood pressure crashes to lethal levels. And because the vessels are chemically locked open by the interaction of those two drugs, it is incredibly difficult to bring the blood pressure back up, even with emergency 5V fluids and vasopressor medications.
That is wild.
The heart suddenly has no pressure to pump against, and the patient can die from the treatment meant to save them. It really highlights why asking about medications, no matter how embarrassing, is just as vital as any high-tech scan.
Speaking of high-tech scans, let's talk about securing objective proof. The verbal history is done, the risk factors are calculated, but human memory is subjective, and panic makes patients unreliable narrators.
Very true.
At what point does the doctor stop taking their word for it and demand physical evidence?
Immediately, honestly. And they are racing against a very specific global standard called the 10-minute rule.
The guidelines state that an ECG, an electrocardiogram, must be performed and interpreted within 10 minutes of the patient arriving at the hospital doors.
Right. The ECG maps the electrical activity of the heart in real time. It's hunting for the E in the shock mnemonic, the ECG abnormalities.
And what are they looking for specifically?
Specifically, it is looking for the electrical signature of a STEMI, which is a massive, full-thickness heart attack, or an NSTEMI, a partial-thickness one. It also spots arrhythmias, which
So, as usual, the AI may sound very well, but it may not sound adequate. So, whenever you come across chest pain in ER, you have to rule out the chest pain that is a cause of death in such patients, and rule out those causes of acute chest pain that may lead to death. And they may include aortic dissection, tension pneumothorax, pulmonary causes like pulmonary embolism, acute coronary syndrome, esophageal rupture, cardiac tamponade, and cardiac issues like pericarditis. Critical threat indicators are usually the pain more than 20 minutes that is exertional previously, are now related with syncope or loss of consciousness, transient loss of consciousness with shortness of breath, low blood pressure or hypotension, diaphoresis, fever and murmur. If it is a tearing pain going to back, it is aortic dissection. If radiating to jaw or arm, it is acute coronary syndrome. Neurological deficit is aortic dissection. Hemoptysis is most probably pulmonary embolism, and sudden onset with absent breath sounds may be pneumothorax. Site onset character, radiation associated symptoms, timing, exacerbating factors are relieving factors, and severity. And OPQRST onset, provocation or palliation, quality, radiation, severity, and time. Both are symptoms, alleviations or exacerbations, allergies, medications, past medical history, last meal, events for complete triage may be included as a sample mnemonic. The pain is mapped by its radiation and localization, whether central, left or right-sided or epigastric. Both arms are left arm to back are remaining in the epigastrium. Character may be pressure, tightness, heaviness, burning, sharp burning, sharp radiating, stabbing, tearing, or pleuritic kind of pain. The chronology of pain is also important. Sudden pain, that the sudden pain is aortic dissection, pulmonary embolism, and pneumothorax, gradual with continued or intermittent. Severity on a scale of 0 to 10 or 7 and above is severe. Exacerbation may be asked about exercise related to respiration, movement, food, stress, cough, or lying flat. In ACS, patient is usually sweating with nausea, vomiting, dyspnea, palpitation, and transient loss of consciousness may be there. In pulmonary embolism, hemoptysis, leg swelling, recent surgery or immobility. In aortic dissection, back pain, neurological deficit, transient loss of consciousness or complete loss of consciousness, pneumothorax with sudden dyspnea and dry cough, and esophageal rupture with retching before pain and maybe subcutaneous emphysema or swelling. You will stratify the vulnerability through H for hypertension, hyperlipidemia, E for elderly or exercise-induced symptoms, age and atherosclerosis, smoking and renal and rheumatic disorders, and diabetes and family history and obesity will help you stratifying the heart risk factors or coronary artery disease risk factors. Patient context is important. For cardiovascular, previous MI, angina, PCI, bypass, heart failure, arrhythmia, valve disorders or congenital. For aortic connective tissue disorders, Melphalan, aortic aneurysm, uncontrolled hypertension, and for venous thromboembolism, previous episodes, cancer, recent surgery, travel, pregnancy, OCP, and for GI causes, GERD, peptic ulcer, gallstones, dysphagia, recent vomiting, COPD, asthma. In pulmonary causes, tuberculosis, pneumonia, and recent infection, especially in a third world country with poor people, the tuberculosis and these things may be considered more importantly, they are to be evaluated. Drug history, phosphodiesterase inhibitors like sildenafil, tadalafil, aspirin, clopidogrel, anticoagulant, statin, nitrates, cocaine misuse, allergies, family history of premature cat, sudden cardiac death, cardiomyopathy, aortic disease or thrombophilia, social history of smoking, alcohol, recreational drug use like cocaine use, occupation, stress, and exercise are also related for the appropriate evaluation of the patient. In ACS, the chest pain is pressure or exertional to left arm or jaw with sweating. In aortic dissection, sudden tearing pain going to back with pulse or BP differences in arms. In pulmonary embolism, pleuritic pain with dyspnea, no radiation, hemoptysis and DVT. Pneumothorax, sudden unilateral pleuritic pain with absent breath sounds on chest auscultation. Pericarditis will have a sharp pain that is relieved while sitting forward with worse on lying flat. GERD is burning after meals, worse on lying down. Costochondritis is localized and reproducible with palpation. Esophageal rupture is severe pain and follows a forceful vomiting. 1 minute synthesis master memory aid is chest pain. Chest pain, C for character and site, H for history of cardiac issues or medications, E for exacerbating relieving factors, S for symptom associated with it, timing, radiation or propagation with P, atherosclerosis and thromboembolic risk factors with A, I with illnesses, allergies and treatment or illicit drug use, and N in the last but not the least, never miss a life-threatening diagnosis or red flags. The main points are every chest pain must be assumed to have acute coronary syndrome until proven otherwise. Pleuritic chest pain suggests pulmonary embolism, pericarditis or pneumothorax, but it does not exclude ACS. Sudden tearing pain radiating to back is aortic dissection until proven otherwise. Always ask about cocaine in young patients with chest pain. And chest pain with syncope, hypotension or dyspnea is a high risk presentation and will need immediate evaluation per local emergency guidelines. Thank you very much. This is Dr. Asifullah speaking from KMUIMS Kohan.